On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
Good morning. Thank you for the opportunity to present to you the results of the PC trial, which is another randomized trial comparing percutaneous PFO closure with medical treatment in patients with cryptogenic stroke. These are my disclosures. As already mentioned by John Carroll, there's no doubt that there is a strong cause-effect relationship between the presence of an PFO and the risk of stroke of unknown origin, which is supported by the consistency of the association and strong dose-response relationship and biologic plausibility, and also numerous reports of proven paradoxical embolism. I think it's also important to recognize that percutaneous PFO closure as performed today is exceedingly safe and also effective to eliminate an atrial right to left shunt. But as just heard from the previous presentation, it is controversial whether it is superior to medical treatment or not. It was against this background that the PC trial was designed with the hypothesis that among patients with cryptogenic stroke and peripheral embolism, PFO closure with the Embolism PFO closure would be superior to medical treatment with antiplatelet agents or oral anticoagulants. Now, the medical regimen consisted of aspirin and either ticlopidine or clopidogrel for a duration of 6 months among those patients who underwent PFO closure, as compared to those patients who were managed medically, who were required to have either oral anticoagulation or antiplatelet therapy, and the regime was decided upon the discretion of the treating neurologist. The inclusion criteria were such that patients had to be less than 60 years old, they had to be in PFO with or without atrial septal aneurysm as documented by transesophageal echocardiography, and those patients not only had to have clinical evidence of stroke and TIA, but also neuroradiological documentation. In the absence of stroke, patients could also be included if they had evidence of an extracranial peripheral thromboembolic event, which was objectively documented with end organ ischemia. Now, the primary endpoint was a composite endpoint of any death from any cause, non-fatal stroke, TIA, and peripheral embolism, and 205 patients per group would have provided 80% power to detect a reduction in the primary composite from 3% to 1%, corresponding to a 66% relative risk reduction at a mean follow-up of 4.5 years. And here you see the next secondary endpoints of the trial. This shows you the flow chart. There were a total of 414 patients who were eligible. 204 were allocated to PFO closure, of whom 191 actually received the treatment. On the other hand, you had 210 patients who were allocated to medical treatment, of whom 200 patients received the treatment. The follow-up was incomplete by withdrawal in 7 patients and lost to follow-up in 24 patients in the PFO closure group, and the follow-up was incomplete due to withdrawal in 11 patients and lost to follow-up in 31 patients in the medical treatment arm group. Here you see the patient characteristics. Patients were young, the mean age was 44 years, and the cerebrovascular index event leading to inclusion in the trial was a stroke in 80% of cases, in TIA in 18%, and peripheral embolic event in 2% of cases. Here you see the primary endpoint, the composite death, non-fatal stroke, TIA, peripheral embolism, which was 3.4% for the PFO closure arm and 5.2% for the medical treatment arm, which was not statistically significant. Here you see the endpoint for stroke. The events were 0.5% in the PFO closure arm and 2.4% in the medical treatment arm, corresponding to a relative risk reduction of 80%, which fell short of statistical significance. Other secondary endpoints are listed here. Overall, there were no differences with respect to bleeding, and there were no differences with respect to atrial fibrillation and PFO-related hospitalizations. I'd like to highlight a few limitations. First, the observed event rate in the medical treatment group with only 5.2%, which was lower than the anticipated 12% at mean follow-up of 4 years. The power of this study was therefore only less than 40%. You may also argue about the composite primary endpoint, as death may be non-specific for the device. TIA may be in soft endpoint leading to dilution of the treatment effect, and that we used in rather historical stroke endpoint definition. The recruitment period was very long, over 10 years, and we also have to acknowledge the attrition rate. So in conclusion, percutaneous PFO closure with the Amplatzer PFO occluder for secondary prevention of thromboembolism showed no significant reduction in ischemic and bleeding events compared with medical treatment in this trial. However, the observed difference in stroke with an 80% relative risk reduction, which translates in number needed to treat of 40 over 5 years, may be clinically relevant if confirmed in other studies such as RESPECT. Thank you very much.
Great. Thanks, Stefan. So let's go straight for more questions first. If not, Ted and Alice, your comments. Oh,
Yes.
Mike.
The long duration that it took, 8 and 10 years for both of these trials respectively, is that even going to be possible? Is this on the radar to be done again, to be tested again?
Well, I highlight it as a limitation because I think what I want to signal is that this is a selected patient population, which may not be representative of what actually happens in clinical practice. And actually tomorrow we will present some more data where we compare the patient population in terms of included into this trial as compared to what we have included in our PFO registry. I think one important thing is the patients included in this trial were at much younger age. And I think there were rigorous inclusion criteria in the sense that most of these patients had a stroke, and even those patients who had a TIA, they had a documented intracranial lesion. So truly patients who have had an objectively verified neurological event. And I think this is something I just wanted to highlight, that this patient population included in this trial and probably also in RESPECT may differ from what we treat in daily practice.
Michelle Cortez with Bloomberg. I'm wondering how you square your results with the other results. Obviously, they're along the same kind of trend lines, but implications: one clearly negative, one questionably negative positive. Second question: reimbursement. Given that we don't have a clear answer here, what's that going to mean for reimbursement going forward? Finally, 5.2% rate in the drug arm is maybe part of the point that these people aren't quite as high risk as we thought, and does it make sense to to be treating everybody going forward?
Yeah, I think these are excellent points. The first one, as you just mentioned, I think one thing we recognize is that all in all, the risk of recurrence is fortunately rather low. And therefore, the event rates or the hypothesis we used to formulate the power of our trial was overly optimistic and unrealistic. On the other hand, obviously, for affected patients, it's good to know that overall the risk of recurrence is low. For us, it is more difficult to detect a difference. Now, what I can say also is I think it will be necessary, and it has been alluded to by Alice Jacobs, to look at the trials together. And what I can tell you is that we used a rather historical stroke definition, that is, patients had to have symptoms for more than 24 hours plus neurological evidence. The stroke definition used in RESPECT is much more contemporary, and actually if we would calculate the hour stroke event rate with the more modern definition used in the RESPECT trial, our differential would be even higher. The p-value would come out as 0.08, and I'm sure if we pull data from RESPECT and PC, you will see that there might be a good chance that they are significant. So I think in this situation of ambiguity, the next step to do is to do a pooled analysis in order to understand more what the benefits of this therapy are. And I am in agreement with you, probably we have to do further research to identify who are those patients who benefit the most.
Great. So reimbursements.
I'm from Europe, so I can't answer that question.
I think that the reimbursement issue also gets at the question of the low event rates and how many patients you actually have to treat in order to prevent an event from occurring. But it's interesting because with the medical therapy of Coumadin. So, for instance, in your trial, Coumadin was used as a primary anticoagulant in a majority of the patients. That's something that patients will have to do for a long period of time, come in for INR checks, and it'll be interesting to see in terms of cost effectiveness. But again, it comes back, I think, ultimately to the individual patient, a one-stop fix versus medications over an extended period of time is something that's a difficult decision for many patients and physicians.
Roger Sogel with MedPage Today. I'd like to ask you, Ajay, and the other discussants on the panel, I know doctors don't treat numbers, but if you were presented, if somebody came to you and presented you the numbers for the results, for the primary endpoints, for these 3 trials and said, so does it look like this is an exciting new treatment? What would you say?
I'll let Ted and Alice answer first.
I want to address the doctors don't treat numbers comment that somebody made just a second ago, which is absolutely the case. It's wonderful to talk about low risk of recurrence at the podium. But when you're facing a 25-year-old who has a partial speech deficit and has lost some of the motor function in their right arm, and you're talking about an infrequent recurrent event, it has a different tone. So it is the magnitude of the clinical event that we're talking about. Disabling stroke for many people is a tougher discussion than a mortality endpoint. And that's why we're still at it, trying to establish the relative risk reduction and why it's such an important discussion. So that's one of the facets of this that's very real and palpable. And to answer your question specifically then, this does not change the discussion that I have with an individual patient. That is, we until now have had a growing body of circumstantial or indirect evidence that PFO closure reduces recurrent events in some patients. And this is another step in that evidence base. It is not the home run P less than 0.001 that sort of makes it a no-brainer discussion. What it remains is the type of clinical discussion we have with most of our patients about most therapies, where we're dealing with a great deal of uncertainty and we use the available evidence to our best ability. Another thing looking forward is there's another randomized trial enrolling that uses even CRISPR neurologic imaging criteria for entry, and that's the REDUCE trial with the Gore Helix device. And the entry criteria include all of the clinical factors, the age below 60, etc., and positive brain imaging. And the brain imaging has to be adjudicated by a neuroradiologist as probably embolic, so that we even screen out the lacunar stroke, but otherwise positive imaging. So we're going to...
I think we have to move on to Alice. Just final comment.
I agree with Ted, and I've spent the past several years working on the guidelines, and I think that nothing really trumps, including the guidelines, a physician faced with a patient sitting across the table, looking at specific circumstances in your specific hospital in your specific region of the world. But I think that's the exact reason why this field has suffered so, and it's been so difficult to do these trials, because you can be sympathetic to a physician looking at a young person with an unexplained stroke who's horrified and fearful of having another stroke, and you think you have a device that could help him. But wearing my guidelines hat, I think that it's very difficult to amass the evidence base that will inform guideline recommendations, because we can't do the trial because we think we already know the answer. And we've seen that in many trials. And I think this trial might spearhead a discussion about that. How do we really enroll patients in trials when we think we know the answer and we're so passionate about helping patients?
That's right. I think it's tough, in summary, to recommend this for every patient with a guideline-based recommendation. But many physicians, I think, would like to have the choice to be able to at least have that discussion with their patients. And then we have to do a better job at picking which patients might perhaps benefit and which patients for whom it wouldn't.
One quick comment. It's clear that the therapy is, device therapy appears not worse. And we have many patients, just for example, young people who are engaged in contact sports. I've got patients of my own, karate, whatever, young women planning pregnancy, where getting off of anticoagulant therapy is a huge benefit, and we can't lose sight of that as a therapy option as well.
Great. One follow-up question.
Very quickly, Dr. Jacobs, in your opinion then, this is not guidelines changing data from these two trials?
So I wouldn't say that prior to having the guidelines committee really reviewing the data in aggregate and totality and looking thoroughly at these trials. I think that's what the guideline committees are about. So more to come, but certainly these two trials will be viewed by the guidelines committees.
Great. Well, thanks so much, Stefan.